Assalamu alaikum warahmatullahi wabarakatuh. Dear students, I hope you're all well. Today we will start revision lectures. So you have to go through the whole course in these lectures. So first lecture is on antenatal care. We'll start from obstetrics. Bismillahirrahmanirrahim. You know, and what do you understand by antenatal care? As the word indicates, ante means before, natal is birth, care, care. So the care which is given before birth, that is during pregnancy. The learning objectives of today's talk are to understand the principles of routine antenatal care, to be aware of the rationale for and purpose of clinical investigations during each trimester, and to differentiate normal pregnancy symptoms from potential underlying pathology. So these are the objectives of today's talk. Antenatal care is a care provided to pregnant women to optimize the outcome of pregnancy. So we can optimize her pregnancy outcome by giving a standardized care. It can also be defined as comprehensive health supervision of a pregnant woman before delivery, or it is planned examination, observations, and guidance given to the pregnant lady from conception till the time of labor. So it is a planned care given to a pregnant woman. Now, what are the aims? Why we are caring a woman during pregnancy? The aims are to optimize pregnancy outcomes for women and the babies, so that we have good outcome of the pregnancy. If we will not give a good care during pregnancy, she may have complications. It may affect her health and also the health and life of the baby. So we have to optimize the pregnancy outcomes by giving a standardized antenatal care. The second aim is to prevent, detect, and manage those factors that adversely affect the health of mother and baby. So we have to identify the high risk factors which will affect her pregnancy. To provide advice, reassurance, education, and support for the woman and her family. So we have to educate and give certain advices and psychological support for the patient and her family. To deal with the minor ailments of the pregnancy. So during pregnancy, she may have minor complaints, minor symptoms, some ailments she encounters. So we have to deal with that, those minor ailments also. To provide general health screening. So there are certain infections, there are certain conditions, medical disorders which should be screened during pregnancy so as to optimize a good outcome. What are the goals of antenatal care? It is to reduce maternal and perinatal mortality and morbidity rates. Secondly, to improve the physical and mental health of the women and the babies. What is the importance? It is to ensure that she and her fetus are in the best possible health, to detect early complications and to treat them promptly, to offer education for parenthood, to prepare the woman for labor, lactation, and care over her infant. So we are preparing her for the process of labor, for the process of delivery, for breastfeeding, and also we'll be preparing her how to take care of her baby. So that's why we have to give good, optimum antenatal care. These are the benefits. Same repetition of all those things that I've said earlier. Early detection of conditions that may cause problems in pregnancy, like high blood pressure, diabetes, or any other medical disorder. Early identification of women who may have complications in labor. Identification of pregnancies where the child may have problems with growth or development. Helping to develop a plan for if things go wrong, if there is certain complications if they ever during pregnancy, then we must have a plan. Allows your caregivers prepare ahead for your delivery and teaches the patient about caring for the baby, where to get help or ask questions. See, these are the benefits of the antenatal care which is given to the patient. This is the schedule for antenatal visits. The first visit or initial visit should be made as early in pregnancy as possible. It is called the booking visit, the first visit. Return visits are at interval of 4 weekly till 28 weeks. Then she will come for antenatal checkup 2 weekly after every 2 weeks till 36 weeks. And after 36 weeks, she will come after every week till 40 weeks. And if we are planning to prolong her pregnancy, then she will come twice a week till 42 weeks. So this is the frequency of antenatal visits in a low-risk patient. So the antenatal assessment includes, or antenatal care includes assessment of the patient through her history taking by thorough examination and with the help of certain investigations. So this is how we will assess the patient during antenatal care, whether her pregnancy is going smooth or there is any complication. The booking visit is the first visit, which is usually at 10 weeks of gestation. First of all, we have to confirm the pregnancy. Sign and symptoms of pregnancy may lead towards that the patient may be pregnant, like breast tenderness, nausea, vomiting, amenorrhea, and increased urinary frequency. The confirmation of pregnancy is done by urine for pregnancy test, which can be tested with the help of a strip. Serum beta HCG, which is a lab test, and also by doing ultrasound, which is called the routine ultrasound. The first ultrasound, which is done, is called the prenatal. So as soon as you know that you are pregnant, seek antenatal care for emotional support and advice, for medical care, and for relevant and timely pregnancy information. So respectful care throughout pregnancy will help protect patient and her baby's health. This is the slogan of World Health Organization, WHO. So on booking visit, first of all, we will take a detailed history from the patient, do examination, do certain series of routine investigations, and during this process, we will identify the risk factors in this patient. Booking visit is usually at 10 weeks of gestation. On initial contact, we must confirm the pregnancy and advise folic acid supplementation. On history, we'll start from history of present pregnancy. You all know how to take a history, obstetric history. We will start from gravidity, parity, RLMT, EDT, calculated duration pregnancy, then the main complaints, past obstetric history, past gynecological history, medical and surgical history. Also, we will take family history regarding any complications, any multiple pregnancy and gender abnormalities in the family, social history, age and racial origin is also very important because there are certain disorders which are linked with race, ethnic distribution, which has ethnic distribution. So the booking examination includes general physical examination, accurate measurement of the blood pressure, abdominal examination to record the size of the uterus, and any scar marks for previous the surgery, measurement of height and weight, with the help of which we will calculate the BMI, that is body mass index. BMI has very significance in the, during pregnancy, because high BMI and very low BMI, they are associated with certain complications. Urine depth testing for proteins, glucose, leukocytes, nitrates, and blood, it is done. Physical examination include examination of height. If it is over 150 centimeters, it means that she has an average size pelvis. If it is less than, she is short statured, less than 150 centimeter height, then she may have a contracted pelvis. So height is very important. The approximate weight gain during pregnancy is according to the BMI. If BMI is between 18.5 to 24.9, the average weight gain, it should be 11 to 16 kg during pregnancy. And if she is overweight, that is 25 to 29.9 BMI, then the weight gain is little less, that is 7 to 11 kg. And if she is obese, then more than 50 kg BMI, then the weight gain should be 5 to 9 kg. So this is the recommendation of weight gain during pregnancy. Obesity leads to an increased risk of gestational diabetes, pregnancy with hypertension, and thromboembolic disorders. So that's why we must take BMI, and the weight gain should be according to the BMI. A local examination or static examination includes the abdominal examination, which includes the measurement of the fundal height, symphysis fundal height. The uterus may be larger than the expected date due to large fetus or multiple pregnancy, that is if she has twins or triplets, then the fundal height will be larger. She has polyhydramnios, or if she is mistaken date, she has forgotten her dates of last menstrual period, then there may be, uterus may be larger or smaller. The uterus may be smaller than expected due to small fetus, intrauterine growth restriction, if the liker is less, low hydramnios, or if again she is mistaken dates. Then we hear the fetal heart sounds. It can be with the help of a sonic aid or stethoscope. With the help of sonic aid, we can hear as early as 10th week of pregnancy. But with the help of stethoscope, it will be after 20 weeks. By Pinard's stethoscope, fetal heart, they are heard after 20 weeks. So this is Pinard's stethoscope, and she is hearing the beating heart. And this is the maximum height of fundus, symphysis fundal height, which is calculated from the upper part of the pubic symphysis till the maximum height of the uterus. So this is how we hear the fetal heart sounds with the help of Pinard's stethoscope. We can also hear the fetal heart sounds with the help of a sonic aid, which is a Doppler instrument. We apply the probe on the maternal abdomen on the side of the back of the fetus, and we can hear tuck 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 on the sonic aid. What is the general advice which is given regarding diet during pregnancy? There are RCOG guidelines or recommendations that she should not eat for the two. She will not eat too much that she has to eat for two. She will only eat for one. Secondly, she should have fiber-rich foods, which has increased number of fibers. It includes fruits, fresh fruits, vegetables, and cereals, which contain a lot of fiber. So she should take fiber-rich diet. She should also base her meals on starchy foods, which has increased carbohydrate content, like wheat, flour, potatoes, bananas. So these are the foods which should be taken more. Restrict intake of fried foods, soft drinks, and confectionery. These bakery items, they should be said no. And other foods high in fat and sugar. So all those things which are rich in fat and sugar or fried foods, they should be restricted. Eat 5 portions of fruits and vegetables each day. So uh, she should take in between meals fruits and vegetables, at least 5 portions. Dieting in pregnancy is not recommended. You should not diet during pregnancy because it will affect the growth of the baby. Now, what is general advice regarding exercise during pregnancy? Aerobic and strength conditioning exercise in pregnancy is safe. The main aim is to remain fit rather than to reach peak fitness. So she should be fit. Contact sports should be avoided. If coexisting medical illness or she has some diabetes or hypertension or some any other disease, medical disorder, then she needs a more tailored exercise program. So a tailored exercise program should be advised to her. Pelvic floor exercises during pregnancy and after delivery may reduce future urinary and fecal incontinence. So, what are the pelvic floor exercises? These are the exercises which are advised to patient during pregnancy and even after childbirth. In this exercise, what we instruct the patient to hold her breath and contract her pelvic floor muscles, just like we are holding a urine and stool. And she will count 1, 2, 3, 4, and then she will slowly release the breath and also relax her pelvic floor muscles. So this is how she will repeatedly doing these exercises. So what it will do, it will strengthen, it will tone up the pelvic floor muscles. So it will help in her delivery, and also it will help during perfusion to retain her tone of the muscles, pelvic floor muscles. And these pelvic floor muscle exercises, they should be done about 100 times in a day. Whenever she remembers, she will start doing the exercise, whether she is sitting, she's walking, she's standing, or she's lying down. She does not need a specific posture for that. So, what is the benefit of these pelvic floor exercises is to reduce future urinary and fecal incontinence, which is due to the loss of the tone of the pelvic floor muscles. Now, regarding breastfeeding, we have to prepare her for the breastfeeding also during pregnancy. So, what are the benefits of breastfeeding? Breastfeeding protects against diarrhea in common childhood illnesses such as pneumonia and many other diseases. So, why it protects against diarrhea? Because it contains immunoglobulins. The colostrum, which is the initial feed, which is coming soon after the delivery, the yellow fluid is the colostrum, and it contains an excessive amount of immunoglobulins. And when these immunoglobulins are taken by the baby, it will protect the baby from these diseases, diarrhea and other illnesses like pneumonia. So another benefit is it reduces obesity in later life. The breastfed babies, they have higher IQ level. So what WHO recommends that the breastfeeding should be initiated within 1 hour of birth, and exclusive breastfeeding is done for the first 6 months of life, in which we will give nothing, only and only breast milk, and it is continued till 2 years of life. Early education during pregnancy about breastfeeding is advocated to improve uptake and engage pregnant lady with breastfeeding services to allow them to be prepared. So during this time, we must prepare the mother for breastfeeding in the puerperium. There are minor complaints or minor ailments of pregnancy, which are nausea, it may be excessive sometimes, which lead to vomiting also, heartburn, constipation due to defect of progesterone. It will relax the smooth muscles of the intestine and she will have constipation, shortness of breath, swelling of legs and feet, backache. She will may complain of backache due to increased lumbar lordosis. She may have abdominal discomfort due to stretching, overstretching of abdominal muscles as the uterus size increases, and she may have headache also. Other common issues include food hygiene, dietary advice, and vitamin supplementation. The risk of smoking and alcohol consumption should be explained to her. Use of medications, recreational drug misuse. Uh, if she's taking any uh, alcohol or she's taking any these recreational drugs, then she should be advised to stop them. Exercise, mental health issues, foreign travel, and DVD prophylaxis. All these issues they should be addressed during pregnancy. All aspects of antenatal care should be covered. Labor discussion, breastfeeding, and care of a newborn should also be discussed during pregnancy. What are the investigations she should have on booking? These include CBC, blood grouping and RH antibodies, RH factor, urine analysis, if needed, urine pathogen sensitivity. Viral screening includes rubella, HIV surface status, hepatitis B and C screening, and she should also be screened for hemoglobinopathies. The most common is thalassemias. These are the booking investigations, and this is the justification why we are doing these investigations for blood count for CBC. It is to see the hemoglobin level, to see the level of anemia and type of anemia, to see the platelet count and mean post volume. MSU midstream specimen of urine to see asymptomatic bacteria. Sometimes the patient has no urinary symptoms, but when you do midstream specimen of urine, it contains bacteria and shows infection. So asymptomatic bacteriuria should be treated. Blood grouping and RH factor to see the rhesus status and atypical antibodies. Then hemoglobinopathy screening. It is based on triply observed questions and blood test results. Infection screening include hepatitis B, C, syphilis, HIV, rubella, and scans include dating scan and the first trimester screening of trisomy 21, 18, and 13. So these are the booking investigations and justification. Other investigations which can be done are screening for vaginosis, cytomegalovirus, toxoplasmosis, streptococcus, staph smear, cervical screening, and high vaginal swabs to rule out any rotator infections. Now, what is the role of antenatal urine testing? What do you think? The role of antenatal urine testing? As I told you, asymptomatic bacteriuria is associated with increased risk of preterm uh, delivery and pyelonephritis during delivery. So, midstream specimen of urine is sent for culture sensitivity at booking visit. So, what do you understand with a stream specimen of urine? When you ask the patient to discard the early stream and the last portion of the stream, and she will take the specimen only from the midstream. First of all, she will clean her vulva and vagina, apart her labia, and then she will discard the early stream specimen. Also, the after the last part of the stream, she will take the specimen only from the midstream, and it is sent for culture sensitivity. So, whenever we send urine, it is screened for proteins, for glucose and nitrates. Proteins to detect any proteinuria for preeclampsia and renal disease, and glucose to see persistent glycosuria to detect gestation diabetes mellitus or if she has pre-existing diabetes. Nitrites are used to detect for presence of UTI. If she has detectable amount of nitrites, then she should be treated for urinary tract infection because it may lead to complications during pregnancy if untreated. Now, blood pressure assessment. Blood pressure is very important on every antenatal visit. The patient should be checked her blood pressure, and it is checked on um, sitting or lying down position. Blood pressure falls a few millimeters in the first trimester. What happens in the first trimester? There is vasodilatation, and there is fall in blood pressure a few millimeters in the first trimester. And in the second trimester, the blood pressure rises again to the pre-pregnancy level. So blood pressure measurement in the first trimester, if she has high blood pressure in the first trimester, it shows that she has chronic hypertension. This hypertension present before the pregnancy and it was undetected. So this will enable us to start antihypertensive treatment, and we will also start low dose aspirin to improve the maternal and fetal outcome. If we will not check blood pressure and she had chronic hypertension, then we will not know, and we will not start the treatment and we will not give her low dose aspirin. So what will happen? She may progress to preeclampsia, or she may develop fetal growth restriction, or she may develop preeclampsia later, which may be worsened by the eclampsia. So that's why we must take blood pressure on every visit, especially in the first trimester is very important. This is how the blood pressure is taken in sitting position. Now regarding scan, the first scan is the dating scan, and what are the first trimester screening tests. The dating scan is done at usually at 11 plus 3 weeks to 13 plus 6 weeks. We will measure the chromosome length. It will give us the gestational age and head circumference also. BPD, femur length, head circumference, and abdominal circumference. It is taken after the first trimester. So first trimester screening involves nuchal translucency, that is thickness of the nuchal region. Measurement of the maternal free beta HCG, pregnancy associated plasma protein A. Maternal age is also included in the first trimester screening, which is 40 or above 40 years of age, then she is a high risk. Uh, so with the help of these nucleotranslucency, maternal free beta HCG, and pregnancy associated plasma protein A and protein age, or with all these we can detect trisomy 21 in 90% of cases. The second trimester screening includes anomaly scan, protocol test, and test. Anomaly scan is done between 20 to 22 weeks, and protocol test, it is maternal fetal protein, HCG, unconjugated estriol, and A, which are detected in maternal serum. So it has 80% detection rate of the congenital abnormalities. Oral glucose tolerance test is done at 24 to 28 weeks of patients, so as to detect gestational diabetes. So with the help of history, examination, and investigations, we will identify the high-risk women. So what are the high-risk women? Those who may develop preeclampsia, they may be at risk of preterm delivery, they may have fetal growth restriction, or they may have vitamin D deficiency or gestational diabetes. So what are the risk factors for gestational diabetes, that is GDM, or risk factors for preeclampsia? For GDM, if she is obese, more than 30 BMI, if she delivered previous good size baby, whose weight was more than 4.5 kg, previous she had history of gestational diabetes, or she had family history of diabetes in the relatives, and if she belongs to South Asian, Black Caribbean, or Middle Eastern family background. So these are the risk factors for developing gestational diabetes. Or if she has polyhydramnios, this is also another risk factor for developing gestational diabetes. So risk factors for preeclampsia include if she is above 40 years of age, She is nulliparous, that is, she's priming gravida, and if her pregnancy interval between two pregnancies is more than 10 years, or she has family history of preeclampsia, previous history of preeclampsia in pregnancies, or her BMI is more than 30, she has pre-existing renal or vascular disease, or she is having multiple pregnancies. So these are all high risk factors for developing preeclampsia in this pregnancy. So we will identify these risk factors by taking a good history. Now how will we screen for preeclampsia? We will take her blood pressure. We will do urine dipstick to measure the proteinuria. We will do Doppler study of uterine artery in the first and second trimester at 24 weeks of gestation. So we will do Doppler ultrasound of uterine artery, not umbilical artery. This is uterine artery. So we will do Doppler study of the uterine artery at 24 weeks of gestation. Women at high risk of preterm birth. So previous preterm birth, if she had previous preterm deliveries, she had late miscarriage, she had multifetal pregnancy, that is multiple pregnancy, or she had previous cervical surgery, she had bone biopsy or resection of her cervix, or she had meniscus repair, or such patients who have previous history of preterm birth, they should have serial ultrasound for cervical length measurement. So we will do serial scans after 14 weeks to see the length of the cervix. If the cervical length is decreasing, there is shortening of the cervix, then we will apply cervical cerclage. We will apply a stitch around the cervix to prevent the preterm birth. What is oral glucose tolerance test? This is a screening test for diabetes mellitus or gestation diabetes. It is performed at 24 to 28 weeks. Fasting blood sample is taken after overnight fast of 8 hours. Then 75 gram oral glucose is given to the patient after overnight fast, and a sample is taken at 1 hour of drinking that glucose and at second hour of drinking the glucose. So then we will see the values, and if they are impaired or they are very high, then we will label as impaired glucose tolerance, or we will label as diabetes or gestational diabetes respectively. So pregnant women, they are at increased risk of developing vitamin D deficiency because the baby is growing, continuously utilizing the maternal reserves of calcium and vitamin D because the baby needs for its growth of the bones. So there is a great chance that the mother may develop vitamin D deficiency. And also there is certain conditions which will limit the fat absorption, like preeclampsia or renal disease, in which she is continuously pouring proteins and lead to vitamin D deficiency. Daily supplementation with oral polycalciferol or ergocalciferol is safe in pregnancy, which is vitamin D. So the nice guidelines suggest to take 10 microgram of vitamin D supplementation daily in pregnancy. Severe vitamin D deficiency, if it occurs during pregnancy, it may lead to increases of neonatal rickets. Now fetal growth restriction. Sometimes the baby is not growing according to the gestational age. When you measure the fundal height, it is less than the gestational age. So in those conditions, either the baby is either small for gestation age, that is, it is a constitutional small, or either there is fetal growth restriction, that baby is not growing properly. So nice guidelines recommend that simple fundal height, it should be measured from 24 weeks onwards. After 24 weeks, we will start measuring simple fundal height each antenatal visit. It may be, fetal growth may be slow or it may stop altogether. Sometimes the baby is not growing at all. So in those cases, we must do prompt ultrasound to see the growth. Serial scans are done at the interval of 2 weeks so as to see the growth, whether it is in baby is growing or not. So dating scan and anomaly scan. Dating scan, as I already told you, it is done the first trimester at 11 to 13 weeks, and anomaly scan is done at 20 to 22 weeks. They are recommended scans. They must be done. And the third scan, the growth scan in third trimester is optional. It only is indicated if there is any suspicion of fetal growth restriction. Then we will do a third scan. Otherwise, the recommended scans, they are only to dating and anomaly. So growth scan is only needed if we have any suspicion in the growth of the baby. Now, how frequently the antenatal visits are done? So, according to NICE guidelines, the first initial contact for confirmation of pregnancy and 10 weeks visit. At 10 to 14 weeks, we will do dating scan, and at 16 weeks, we will call her for these screening tests, biochemical tests. We will measure her blood pressure and we will check her proteinuria with the dipstick. At 18 to 20 weeks or 22 weeks, we will do an anomaly scan. At 25 weeks, if she had previous history of preeclampsia or she is high risk of preeclampsia, we will call her at 25 weeks and we will do her urine for proteins, check her cervical fundal height, and also check her blood pressure. Then she will come at 28 weeks. We will check her blood pressure, her proteinuria with dipstick, measure her cervical fundal height. We will screen her for anemia. That is, we will check her CBC, red cell antibodies, and if she is Rh negative, we will give anti-D prophylaxis in case her husband is Rh positive. At 31 weeks, we will call her again to check her blood pressure, proteinuria with dipstick, and check her cervical fundal height. 24 weeks, we will check her blood pressure, proteinuria, and cervical fundal height, and we will give her information regarding her birth and labor, because now she may be at risk of going into preterm labor. At 36 weeks, she will come again and we will give information regarding breastfeeding, vitamin K for the newborn, and care of the newborn, postnatal issues, preparation for fetal presentation, or lie, and blood pressure, proteinuria, and cervical fundal height. And she is also given vaccination for tetanus as well. 48 weeks, same things they are repeated. And at 40 weeks, again, we will do same check her blood pressure, cervical fundal height, proteinuria, and presentation, fetal heart sounds, her fetal K count. If all is okay, there is no risk factor, then we can wait till 41 weeks. And at 41 weeks, we will do membrane swapping. Induction is planned if it is advisable. Induction of labor. This is immunization schedule for a tetanus toxoid. There are 5 doses of tetanus toxoid. The first dose is given at initial contact as early as possible during pregnancy. The second dose is given 4 weeks apart. It gives 80% protection, and the duration of protection is for 3 years. And third dose is given after 6 months of the second dose. It gives 95% protection, and it is for 5 years. Fourth dose is given after 1 year of the third dose, and it has 99% protection for 10 years. And then booster dose is given after 1 year, which gives protection 99% for about 20 years. So this is the WHO immunization schedule for tetanus toxoid. Now, what are the common pregnancy problems and their management? As I told you earlier, exercise should be simple, mild, toward heavy weightlifting, A tooth can be extracted if she has any problem with her tooth. She can get it extracted during pregnancy, but local anesthesia is recommended. She should not take general anesthesia. Smoking should be stopped because it may lead to tiresome nervousness and hyperemesis and may pregnant women at increased risk of chest infections and thromboembolic disorders. So she should stop smoking. Avoid contact with infectious diseases, especially rubella, German measles, because it has deleterious effects on the fetus. So she should avoid infectious diseases. Rubella हो गया, chicken pox and such infections. Avoid exposure to X-ray radiation because of possible teratogenic effects on the fetus. It may lead to birth defects or child. There is increased urinary frequency. So what she should do? She should take less fluids at night, maintain fluid intake during day, and void when she feels the urge. She should not hold urine for a longer time because it will lead to UTI, urinary tract infection. For nausea and vomiting, she should avoid food or smells that exacerbate her condition. So there are certain foods and smells that lead her to nausea and vomiting. So that should be avoided. Eat dry crackers or toast before rising in the morning. Eat small, frequent meals. Do not take a big meal. She should take small, frequent meals, at least 6 portions per day. Avoid sudden movements. That is getting out of bed, suddenly jumping out of the bed. She should get out of bed slowly and breathe fresh air to help relieve nausea. So these are the general measures. She has increased heartburn. For that, eat small, more frequent meals. Antacids should be taken and avoid overeating and spicy foods. She may develop dependent edema of the feet and leg. Avoid long-term standing. And whenever she feels tired, she should lie down, elevate her legs, even in sitting position. Avoid tight stockings. Sometimes during pregnancy, varicosities develop. So what she should do, she should rest in Sims position, that is in the left position. Elevate legs regularly. Avoid crossing legs. She should not sit while crossing her legs. Avoid tight stockings and long periods of standing. So what are the key points or take-home message of today's talk? That antenatal care improves maternal and fetal outcomes. So we are giving antenatal care to improve the outcome of pregnancy for both mother and fetus. There are key visits during pregnancy when essential investigations and decisions are taken regarding antenatal care and delivery. Antenatal care should be seen as an opportunity for education, reassurance, and screening for potential problems. Continued efforts should be made to improve the access to antenatal care for less privileged and minority groups. So this is all about antenatal care. This is your first lecture on antenatal care. We will have another lecture which will be more emphasis will be laid on investigations, and that will be revision of this lecture, and you may be asked questions regarding antenatal care. So be prepared for questions in the next lecture about antenatal care. So if you have any questions, you can ask me, and if you have any queries, you can also ask.